Welcome to the deep dive. Let's be honest for a second. Most of us, we only ever really think about our kidneys when we're stuck in traffic and desperately need to find a bathroom.
Right. It's just a plumbing issue to most people.
Exactly. But today, we are going to completely shatter that perspective. We're looking at a fascinating stack of medical materials specifically, a comprehensive medical lecture, and a detailed slide deck covering pediatric renal disorder.
Module 10, right?
Yeah, Module 10. And what becomes immediately clear from these sources is that the kidneys are actually the body's hidden master regulators.
Oh, absolutely.
So our mission today is to unpack this medical information to understand exactly how the renal system works, why kids' kidneys present totally unique mysteries compared to adult kidneys, and this is the crazy part, how a microscopic glitch in these vital filters can trigger a massive domino effect across your entire body.
It really is a domino effect.
Yeah.
If you want to deeply understand the human body, you have to look at the kidneys. When they fail or, even just stumble, it is not simply a plumbing issue.
It's systemic.
It is a full-blown systemic crisis. We're talking about severe impacts on your blood pressure, your bone density, and even your lungs. The kidneys are holding everything in balance, constantly making micro-adjustments to the chemistry of your blood.
Okay, let's unpack this, because there is a detail right at the beginning of this assessment data that completely reframes how you look at anatomy.
The ear pits.
Yes, the connection between your ears and your kidneys. If a child has physical ear anomalies, say a tiny ear pit that just looks like an old ear piercing, or if they have unexplained hearing loss, pediatricians will immediately screen their kidneys.
Which sounds wild.
On the surface, those two systems seem entirely unrelated.
But what's fascinating here is the embryological timeline. In the womb, the auditory system and the renal system develop at the exact same time.
Ah, okay.
Because their formation is so closely linked on the developmental calendar, a genetic hiccup or an environmental factor that impacts one system is highly likely to have impacted the other. So an external, visible clue, like an ear pit, gives doctors a crucial hint to look inside at the kidneys.
It's essentially like finding a misprint on page 10 of a book and knowing to check page 20 because they were printed on the same press.
That's a great way to put it.
And as you dig into the systemic connections, you see this chaos that happens when the kidneys act up. Kidney issues constantly masquerade as other problems. For instance, looking at the cardiovascular system, a child might present with bounding pulses.
Right.
You might think that's a heart issue, but it actually indicates fluid overload because the kidneys just aren't excreting enough water. Or you might see a capillary refill time of over 2 seconds, which points to poor blood perfusion.
And the respiratory system is another prime example. You might hear a child with a simple cough, or what doctors call adventitious sounds in the lungs.
Like crackles.
Exactly, crackles. It's incredibly easy to misdiagnose that as a simple respiratory infection or a cold. But in reality, it could be fluid physically backing up into the lungs because the kidneys aren't filtering it out of the bloodstream.
Wow.
The lungs are just the victim of the kidney's failure to regulate volume.
And the musculoskeletal system is where this interconnectedness gets really complex. A child might present with unexplained bone pain, poor weight gain, or even early onset osteoporosis.
Which is heartbreaking in a child.
It really is. And the mechanism here is brilliant but destructive. Chronic kidney disease leads to severe electrolyte disturbances, specifically hypocalcemia.
Meaning low calcium in the blood.
Right, because calcium is absolutely critical for basic cellular function. The body prioritizes blood calcium levels over bone density. So when the kidneys fail to maintain that balance, the body literally steals calcium from the growing pans to compensate.
It just robs the bones.
Yeah, that internal theft leads to weak bones, bone pain, and ultimately stunted growth.
If we connect this to the bigger picture, it highlights why establishing baselines is so important. To figure out what's going wrong, we have to look closely at the vital signs of urine.
The hard numbers.
Exactly. Normal urine output for kids is a very specific metric, 0.5 to 2 milliliters per kilogram per hour.
And then you have the specific gravity, which measures the concentration of all the chemical particles in the urine. The sources say that should sit right between 1.001, which is highly diluted, almost like pure water, and 1.035, which is highly concentrated.
Alongside those metrics, you're looking for 0 protein, 0 glucose, and 0 blood in the urine. But the blood tests tell the rest of the story. The ultimate clinical indicator of how well the microscopic filters inside the kidney are working, is a blood lab called creatinine.
Right, the creatinine clearance.
Normally, that should be between 0.6 and 1.2. When creatinine is elevated, it's a clear signal that the filters are compromised and aren't clearing waste from the blood properly.
Which brings us to the actual mechanical failures, or what we might call the plumbing problems. A great place to start is with urinary tract infections, or UTIs.
Sneaky UTI.
Very sneaky. In adults, a UTI is usually obvious. It means painful, frequent urination. But infants and toddlers don't present that way, which makes diagnosing them incredibly tricky.
Right, the presentation is entirely systemic. A baby with a UTI might just have a random, unexplained fever. They might be vomiting or having diarrhea. They lack the ability to localize the pain and tell you it hurts to pee.
And that subtlety is actually quite dangerous, considering E. coli is the most common bacterial cause. If an E. coli UTI is left untreated in a child, the bacteria travel up the tract and cause permanent renal scarring.
That microscopic scar tissue permanently degrades the kidney's ability to function later in life.
So how do they catch it?
To diagnose it properly and prevent that scarring, medical teams have to look at a urinalysis specifically for nitrites, or leukocyte esterase. The presence of nitrates is almost always diagnostic of a UTI.
But getting that sample from a baby isn't easy.
No, it's a challenge. To get a clean, uncontaminated sample from a baby who isn't potty trained, nurses often have to perform a straight catheterization.
Which means inserting a tiny tube directly into the bladder.
Exactly, to ensure the urine culture isn't contaminated by normal skin bacteria. It sounds invasive, but it provides the definitive data needed to save the kidney tissue.
Now, sometimes a child will have recurrent UTIs, and the underlying cause is actually an anatomical issue called VUR, or vesicoretral reflex.
Right, this is a congenital condition where the flow of urine is reversed. Instead of flowing from the kidneys, down the ureters and into the bladder, the urine actually flows backward from the bladder, up the ureters, and back into the kidneys.
It's a failure of a specific anatomical mechanism. There is a one-way valve where the ureter meets the bladder. When that valve fails, urine refluxes.
And the danger here is that any bacteria in the bladder get a free ride directly up into the delicate kidney tissue.
The slide deck mentions this often runs in families and is graded in severity from 1, being very mild, all the way to 5, which involves severe dilation of the ureter.
To diagnose it, doctors use a procedure called a VCUG. They instill a contrast dye into the bladder via catheter and then take a series of X-rays as the fluid moves, visually mapping the reflux.
Mild cases often resolve on their own as the child grows, but severe, high-grade cases require surgical correction to reconstruct that valve.
To prevent irreversible renal failure, exactly.
Switching gears to another mechanical issue, the data on kidney stones in kids is eye-opening. There is a rising incidence of kidney stones in pediatric populations. And it isn't just about severe dehydration or the clinical use of loop diuretics.
It's diet.
It's diet. A massive, everyday culprit is high oxalate foods. When you look at the list of offenders, it's totally counterintuitive. We're talking about spinach, raspberries, rhubarb, dark chocolate, and black tea.
For a health-conscious parent, spinach and raspberries are supposed to be the ideal healthy snacks.
Right. It's a nutritional paradox.
It is. For children who are prone to stone formation, the oxalates in those specific foods bind with calcium and crystallize in the urinary tract. When a stone forms and becomes lodged, the interventions have to be precise.
The sources mention aggressive IV hydration and pain management.
Yes, and doctors might prescribe tamsulosin, commonly known as Flomax. Now, you might recognize that as a drug typically used for enlarged prostates in older men, but its mechanism of action is what's important here.
It relaxes the smooth muscle.
Exactly. It relaxes the smooth muscle in the urinary structures, which helps the child pass the stone naturally.
And if the stone is simply too large to pass, they move to lithotripsy. This is a fascinating procedure where they use a machine to shoot high-frequency ultrasonic sound waves directly through the body at the kidney.
The physical force of those sound waves blasts the solid stone into tiny passable fragments, like turning a rock into sand.
Incredible. Now, moving deeper into the functional tissue of the kidney, we have to talk about the glomeruli. This is where the actual filtration of the blood happens.
I really appreciate the analogy used to describe the glomeruli here. Think of them as the body's microscopic coffee filters.
That's a great visual.
Their entire job is to keep the good stuff like red blood cells and vital proteins inside the bloodstream, while letting the liquid waste and extra water pass through into the urine.
But the clinical data contrasts two major diseases where this filter breaks down in very different ways: nephrotic syndrome and acute post-infectious glomerulonephritis.
Let's examine nephrotic syndrome first. You can think of this as the leaky filter scenario. This typically hits children between the peak ages of 2 to 5 and has a very gradual onset.
So what's happening mechanically?
What happens is structural damage to the glomeruli that vastly increases their permeability. In terms of the analogy, the microscopic holes in the coffee filter get way too big. This allows massive amounts of albumin, which is a critical protein, to leak right out of the blood and into the urine.
Clinically, this massive protein dump actually makes the child's urine look frothy or excessively bubbly.
And losing that protein triggers a massive biological overcorrection. It all comes down to the physics of the bloodstream. Protein in the blood is responsible for maintaining what's called oncotic pressure.
You can visualize oncotic pressure as a sponge that holds fluid inside the blood vessels.
Exactly. When that albumin drops drastically because it's leaking into the urine, the sponge effect is gone. The fluid literally seeps out of the blood vessels and into the surrounding tissues.
This causes severe edema.
Yes, especially periorbital edema, which is distinct swelling around the eyes, and ascites, which causes a severely protruding, fluid-filled abdomen.
The body's attempt to fix this low-protein crisis is fascinating, though entirely counterproductive. Because the protein levels plummet, the liver registers a state of emergency. It tries to compensate by overproducing cholesterol, leading to hyperlipidemia.
So now the child has low protein, systemic swelling, and high cholesterol.
It's incredibly complex, but the slide deck shares a brilliant memory trick used in clinical settings to remember this exact cascade, the edema mnemonic.
Oh, that's right. E stands for extreme swelling.
D is for decreased urine output because all the fluid is trapped in the tissues.
E is for elevated cholesterol.
M is for massive proteinuria, the protein in the human.
And A is for albumin low, specifically in the blood.
To treat this leaky filter, the approach is multifaceted. They use corticosteroids to aggressively drop the inflammation in the kidneys, implement strict fluid restrictions, and they actually administer the Vive albumin directly into the patient to artificially put the protein back into the blood and restore that oncotic pressure.
Now contrast that leaky filter with the inflamed filter, acute post-infectious glomerulonephritis, or APIGN. This condition presents with a sudden onset and typically affects slightly older, school-age children.
What's crucial to understand here is the timeline. The sources emphasize it almost always happens 10 to 14 days after an initial infection, usually a strep infection like strep throat.
This is a point worth pausing on. A child has strep throat, they recover, the sore throat goes away, and then 2 weeks later their kidneys start failing.
It feels like a completely random strike.
It does, but the mechanism is entirely immune-driven. It isn't the strep bacteria traveling down to attack the kidney, it's the child's own immune system causing the collateral damage.
So the antibodies are the problem.
Yes. The antibodies that the immune system created to fight off the strep infection end up circulating through the blood and physically lodging in the glomeruli. This accumulation of immune complexes causes severe inflammation, physically impairing the glomeruli ability to filter waste.
So instead of the massive protein leaks and severe whole-body edema we saw in nephrotic syndrome, you see a different profile here.
Much different. You see milder swelling, hypertension from retained fluid, and a very specific type of hematuria. The blood leaking into the urine oxidizes, turning the urine a dark tea color.
It perfectly illustrates how an immune response in one part of the body can completely compromise an organ system weeks later. This brings us to another set of complex systemic conditions, often referred to in the module as the terrifying triads and tetrads.
HSP and HUS.
Exactly. Let's start with Henoch-Schönlein purpura, or HSP. This condition is defined by the tetrad, which is a specific cluster of 4 symptoms. You have palpable purpura, which is a raised, bumpy purple rash, usually appearing on the legs and buttocks. Then you have joint pain, abdominal pain, and hematuria.
The underlying pathology of HSP is a multi-system vasculitis, meaning inflammation of the blood vessels. On a microscopic level, immunoglobulin A, or IgA, which is an antibody, accumulates and collects inside the small blood vessels.
This abnormal collection causes those delicate vessels to become inflamed and actually leak blood into the surrounding tissue.
That microscopic leaking is what causes that raised, palpable purple rash and the severe joint pain. In most cases, it is a self-limiting condition, meaning the child's body will clear the IgA complexes and recover fully on its own over time.
But the abdominal pain in that tetrad is a critical warning sign. Medical teams have to monitor these patients closely for a severe complication called intussusception.
Because the blood vessels in the gut are inflamed and swollen, The intestine can actually fold in on itself, sliding inside the adjacent section of bowel like a collapsing telescope.
It causes an immediate, dangerous bowel obstruction.
Exactly, which is why close observation is mandatory even if the condition is technically self-limiting. Now, shifting from the tetrad of HSP, we look at the triad of HUS, hemolytic uremic syndrome.
The three defining symptoms here are hemolytic anemia, thrombocytopenia, which means a dangerously low platelet count, and AKI, acute kidney injury.
And the culprit for this triad is something you encounter in everyday life. It's often an infection by a specific strain of E. coli.
But we aren't just talking about poor bathroom hygiene. The transmission vectors include undercooked meat, unwashed vegetables, swallowing water in public swimming pools, or even a kid drinking from a garden hose in the backyard.
It's a stark reminder of how vulnerable the renal system is to common environmental pathogens.
The physiological cascade of HUS is pretty devastating.
It really is. When the child ingests this specific E. coli, the bacteria release potent toxins into the bloodstream. These toxins specifically attack and destroy the red blood cells, which accounts for the hemolytic anemia.
But the destruction creates a secondary mechanical crisis.
Right, as these broken, sheared fragments of destroyed red blood cells continue to circulate in the blood, they eventually reach the kidneys. They physically wed into and clog up the delicate capillary filters of the glomeruli.
This widespread mechanical blockage causes a severe acute kidney injury. Clinically, this process usually begins with a distinct warning sign: severe bloody diarrhea, occurring about 2 to 12 days before the acute kidney injury actually sets in.
It's a perfect storm of infection, cell destruction, and mechanical failure, which leads right into the ultimate question: what happens when the filter just completely stops?
We have to look at the difference between acute kidney injury, or AKI, and chronic kidney disease, CKD. AKI is defined as a sudden, rapid drop in the glomerular filtration rate.
In pediatric populations, this is most commonly caused by volume depletion. Essentially, severe dehydration from intense vomiting or diarrhea drops the blood volume so low that the kidneys simply don't have enough pressure to filter.
Their blood lab tests will show markedly elevated BUN and creatinine levels because the blood is just accumulating unfiltered waste.
The key characteristic of AKI is that it is sudden and, crucially, often reversible with aggressive IV hydration and treating the underlying cause.
Chronic kidney disease, on the other hand, is the progressive and irreversible loss of kidney function lasting for a duration of more than 3 months.
In pediatric cases, unlike in adults where it's often driven by diabetes or hypertension, CKD is most frequently caused by congenital anomalies of the kidneys or the urinary tract that the child was born with.
When the kidneys reach a point where they can no longer sustain life, the medical approach has to shift to renal replacement therapies. We have to artificially perform the complex chemical balancing that the kidneys can no longer manage.
This is where we get into the mechanics of dialysis. There are two entirely different approaches to replacing kidney function. First, there's hemodialysis.
This is the mechanical approach most people picture when they hear the word dialysis. You hook the patient up to an external machine, surgically access their vascular system, pump the blood out of the body, run it through an artificial filter to remove the waste, and then pump the clean blood back in.
It's effective, but it requires the patient to be in a clinical setting multiple days a week.
Then you have peritoneal dialysis, which utilizes the body's own anatomy in an incredibly elegant way.
Instead of pulling the blood out of the body to filter it, peritoneal dialysis happens internally. A hyperosmolar fluid, which is a fluid highly concentrated with specific electrolytes and sugars, is instilled directly into the patient's abdominal cavity, known as the peritoneal space, through a surgically placed catheter.
And once that fluid is inside the abdomen, it just dwells there for a prescribed amount of time. The physics of this are remarkable. Because of the natural laws of osmosis, that highly concentrated fluid acts like a chemical magnet.
It literally pulls the circulating waste products, toxins, and excess fluid out of the surrounding abdominal blood vessels, across the body's own natural peritoneal membrane, and into that fluid sitting in the cavity.
The body's membrane acts as the coffee filter. Once the dwell time is complete, that fluid, which is now saturated with the body's toxins, is simply drained out into a bag via gravity.
It is a profound medical innovation. It turns the lining of your own abdomen into an artificial kidney.
And perhaps the most impactful part of this process is the logistical freedom it provides. Older kids and their parents can actually be trained to perform peritoneal dialysis at home, often while the child is sleeping.
They don't have to be tethered to a hospital bed 3 days a week. It restores a massive degree of normalcy. and gives them their lives back.
So, stepping back and looking at all of this, we've covered some immense physiological ground today. We journeyed from the strange, shared embryonic timeline of ear pits and kidneys to the surprisingly complex urinary impacts of healthy foods like spinach and the dangers of garden hose water, all the way to the sheer mechanical and biological genius of peritoneal dialysis.
Which brings us to why this level of detail matters to you. Whether you are a parent trying to decipher the subtle signs of a toddler's unexplained fever, or just someone looking to appreciate the microscopic marvels that are silently keeping your own blood clean every single second, understanding the renal system fundamentally shifts how you view the human body.
It proves that we are not just a collection of isolated organs operating independently.
We are a deeply interconnected, finely tuned ecosystem where a change in one variable ripples through the entire structure.
It is an ecosystem that demands respect. And I want to leave you with a final, lingering thought to ponder long after you finish listening to this deep dive. We discussed how, because the ears and the kidneys develop at the exact same time in the womb, a visible physical quirk in one can reveal a hidden internal defect in the other. It makes you wonder, what other secret embryological twin systems are currently operating in your own body, completely unnoticed, silently dictating how your future health will unfold?